In this lecture, we're going to be focusing on bronchiolitis. This lecture refers frequently to the prior lecture, Introduction to Shortness of Breath. Our second case is a 2-year-old male coming in with cough and shortness of breath. What do you think when you see him? Overall, he appears fatigued, mild increased work of breathing with very subtle subcostal and intercostal retractions. He is breathing maybe a little fast, but overall okay. This is a child with croup, or laryngotracheobronchitis. Croup is a viral infection of the upper airways, causing edema of the larynx and trachea. The classic symptoms are a barking cough, stridor, hoarseness, along with other respiratory infection symptoms. This occurs in children between 6 months and 6 years of age most commonly. It's usually self-limited, improving in 2 to 7 days. But again, this child may need some help with medications to help them get better more quickly and more surely. Again, the same questions. Ask good history questions. Again, ask a lot about the cough. In case the child isn't coughing in front of you, ask the parent to demonstrate what it sounds like. Ask about the child's health overall. Ask about if they're able to eat and drink and stay well hydrated. Examine this child just like any other. Watch them. Watch their work of breathing like we just did. Then auscultate and listen for these extra abnormal airway sounds. Listen for the same things we always listen for: wheezing, rales, bronchi, and then things like grunting and stridor. Assess other physical exam to help you confirm or dispute your diagnosis. And the neck, in children who are having difficulty breathing, they may position themselves in a way to give them advantage. So this is called tripod positioning, when a child is sitting with his head extended, not moving. This is because this is the one position the child likes. Let the child stay just like they want to stay in that position. Going back to our case, the 2-year-old male, he was born on time and is typically pretty healthy. He has a mild fever at 38.2. His heart rate is appropriate for age, just like his respiratory rate. Although he looks tired, his oxygen saturation is 98%, very helpful for us to know. And his blood pressure is normal at 92/56. On physical exam, he goes on to have a very loud, barking cough. Looking at his face, you see clear rhinorrhea, moist mucous membranes, and no drooling. He's not in that tripod position. He's lying comfortably, and that's very telling. On auscultation, he has excellent air movement throughout his lungs, no wheezing, and very soft stridor. Sometimes it's very soft, and if you hold the stethoscope by the throat, you can hear very, very subtle sounds. Further history, the mom says this really all just started last night, and it seems to be a lot worse at night. The older brother at 8, also sick, but just has a very mild cough and runny nose. There are no smokers in the home, and she doesn't think he ingested or choked on any foreign bodies. Again, you've examined this child. Now what do you want to do, and how can your nurses help you? He doesn't necessarily need oxygen because he's saturating well, but sometimes children with croup feel better when they have some humidified oxygen, so you could try that if it's available. Croup is swelling of the upper airways, so steroids are the most effective and necessary treatment. 2 types are available: dexamethasone or prednisolone, and you can use whichever you have on hand. The dexamethasone tends to last longer and can be given orally, intravenously, or intramuscularly, all with equal efficacy. The steroids take about 4 hours, maybe 6 hours to take effect. So in any child you're giving steroids because they need them, you'll need to have them stay and watch to make sure they're improving until the steroids would have started working. Inhaled adrenaline in a nebulized form is maybe a new treatment that you should consider, especially in a child with croup. This can help open up the airways and make the breathing more comfortable. Especially in a child with stridor, which he had very slight, a lateral and AP soft tissue neck x-ray is really helpful to take a look at the airways. When we're thinking about our differential diagnosis of croup versus other conditions, maybe consider epiglottitis and airway foreign bodies. They will all have stridor. Croup has that barking cough, which sounds like a seal bark. Epiglottitis may or may not have a cough associated. An airway foreign body could have a really dry cough. And it's more of an irritated cough with that child trying to get it out. The more infectious causes will have the rhinorrhea and other symptoms of upper respiratory tract infection. A neck radiograph is helpful on each of these conditions. In croup, you'll see a Steeple sign, which I'll show you an example of. Epiglottitis, on the lateral neck x-ray, you'll see swelling of their epiglottis, causing what we call a thumbprint sign, which is just a swelling of the epiglottis, which is what's causing the impedance of airway flow going down into the lungs. These children tend to look very sick in appearance, and that's something to think about when you have a sick child with clear-sounding lungs who's having difficulty breathing. The third is airway foreign body. If the child did ingest something or choke on something, sometimes you may see it on an x-ray. Let's go through an algorithm for a child with cough. And I've listed here barking cough because this is our kid, our example. On the far left is the most healthy. This is a child who has a barking cough but is breathing very normally, otherwise well appearing. This is a child who may not need immediate intervention. You can reassure the parents, continue oral hydration, consider steroids if that's going to help the child be more comfortable and help the child breathe. This is a child who could be discharged home. The middle category is a child who has slight stridor, slight tachypnea, and a persistent cough. This is a child where steroids will definitely be beneficial. They'll help decrease that edema, make the child more comfortable. After observing the child for 4 to 6 hours, reassess and decide if this child's going to be able to go home or if this child will need to be admitted for continued increased work of breathing and severe cough. The last category on the right is the child with a severe cough and severe stridor. Now, stridor, remember, can be associated with multiple causes, and a neck x-ray would be very beneficial. So our child had barking cough and severe stridor. Think about immediately giving humidified oxygen, steroids, and nebulized adrenaline. This is a child who will need to be admitted to the hospital, potentially to an intensive care setting with intubation if necessary. This is a radiograph of the Steeple sign. This is an AP neck radiograph of a child. The airway, which you can see around the trachea, should be nice and open, but this one has a Steeple sign. You can see that the airway is closed, showing the severe narrowing from edema from the infection. This is why the child is having difficulty breathing, because the air is not passing through as easily as it typically does. Some similar myths apply to croup as they did in bronchiolitis. Again, a radiograph in this is very useful to differentiate epiglottitis from other airway infections or causes. An oxygen saturation is very helpful. Our child in this case looked like he could have been sick because he was kind of lethargic, but realizing that he wasn't tachypnic and had a normal oxygen saturation reassured you, knowing that he was more tired because he hadn't slept rather than from being in distress. So oxygen saturation initially and after interventions is very helpful to ensure your child is improving and to see what further treatment he needs. In summary, children with shortness of breath look for signs of respiratory distress and dehydration. In a child with both upper respiratory infection and a barking cough, think about croup. In children with stridor, think about a neck x-ray to help you with your differential. Steroids and nebulized adrenaline are very helpful for croup. Humidified oxygen may make the child more comfortable. If the child is in distress, keep them in their preferred position of comfort. Intubation may be required. As always, aggressive initial airway treatment may prevent subsequent intubation.